Hi, everyone. I'm Dan Gillison. As the Chief Executive here at NAMI, I am pleased to welcome you to our 2021 Scientific Research Award event, Inspiring Hope Through Research. While we had hoped to gather in person this year, due to the highly contagious Delta variant, we decided to return to a virtual format for the second year in a row. We're so glad that we can still hold this event while protecting everyone's health and safety. Today, we celebrate the extraordinary accomplishments of our 2021 honorees, Doctors Gail Dommett and A. Eden Evans. Their work reflects their sincere dedication to improving the lives of people affected by mental health conditions. They join an illustrious group of researchers whose work over the years have helped move the understanding and treatment of mental illness forward. As the nation's largest grassroots mental health organization, NAMI is dedicated to building better lives for the millions of Americans affected by mental illness. And one of the best ways we can do that is through supporting and advocating for research. Scientific research brings us closer to the resources necessary to sustain a healthy and productive life. And in this way, research provides one of our most important strategic values here at NAMI, hope. Thank you, Dr. Dommett, Dr. Evans, for all of the work you have put into bring people hope. Your research is truly impactful, and we're so honored to have you here with us today. With that, I would like to ask Dr. Ken Duckworth, NAMI's Chief Medical Officer, to join us now in discussions with our honorees. Dr. Duckworth?
Thank you, Dan, and thanks everybody for attending. We have some very noteworthy firsts this year. Dr. Gail Dommett is the first internist to ever win our scientific award because of her superb work in cardiovascular prevention for people who live with serious mental illness. And Dr. Eden Evans is the first resident of mine to ever win the scientific award. When we both were young, and she was younger than I was, I had no idea that she would become a national, international expert on smoking cessation for people with serious mental illness. The other first, which is noteworthy, these are the first set of friends who are winning our award. With that, I'm going to have them introduce each other as only good friends can do. Take it away, Gail.
Eden, would you like to start?
Sure. Thank you, Dan, and thank you, Ken, and thank you to the Cones for supporting this research. It's just such a pleasure to introduce my good friend and dear colleague, Dr. Gail Dommett, who's sharing this NAMI Scientific Award with me. Gail is fabulous. Gail is a fantastic leader of teams and a fearless scientist, and there's no one more deserving of this award. As Ken mentioned, Gail's different from other previous NAMI awardees. She's not a psychiatrist, not a psychologist, or a neuroscientist. She's a primary care doctor, a general internist, as we call it, who's devoted her career to improving the physical health of persons living with serious mental illness and reducing their 10 to 20-year premature mortality due to cardiovascular disease. Gail addresses these issues rigorously using methods from descriptive epidemiology to health services research to clinical trials, and now to community engaged implementation science to promote the widespread adoption of evidence-based practices to improve cardiovascular, heart disease risk factors in persons living with serious mental illness. Gail's the Samsung Professor of Medicine and the Vice Dean for Clinical Investigation at Johns Hopkins University School of Medicine. She's the director of the NIMH-funded Johns Hopkins Alacrity Center for Health and Longevity in Mental Illness that is devoted to accelerating translation of interventions to decrease premature mortality in persons with serious mental illness. And I'm privileged to work with Gail as a co-investigator in this center. Gail is super productive as an investigator. She's had continuous NIH funding since the year 2000. She's received funding from the Brain and Behavior Research Foundation, has over 100 peer-reviewed papers, and she's mentored over 25 promising young doctors and as mentees, and received the Johns Hopkins Mentoring Award. Most importantly, though, she's collaborative, generous, and passionate about what she does and is highly dedicated to her work. And this is reflected by the high impact that her work has had and the real world implications for persons living with serious mental illness. So Gail grew up in the Maryland suburbs of Washington, D.C., so she hasn't moved very far in that regard, but she earned her undergraduate degree at the University of Pennsylvania, her medical degree at Emory University, her master's of health science in chronic disease epidemiology at the Johns Hopkins Bloomberg School of Public Health. She completed her residency in internal medicine up here at the Massachusetts General Hospital, and then she returned to join Hopkins in 1996 as a Robert Wood Johnson Clinical Scholar, and then joined the Faculty of General Internal Medicine in the Faculty of Medicine. So Gail started her career, and I think where we start is super important. When she started her research career, right about the time that olanzapine was being recognized as having the potential to cause serious weight gain for the people who used it. Yet there were almost no well-designed studies of the prevalence of obesity in people with serious mental illness. And Gail conducted important early observational studies of cardiovascular risk factors and premature mortality. But then she felt she really needed to do something to actually improve physical health rather than just observe it and report, although that was super important. Her mentors were experts in the NIH-funded lifestyle interventions for hypertension and weight management. And Gail realized that these types of interventions were needed for persons living with serious mental illness, but may need these interventions tailored to their needs. So she turned to work designing and testing these behavioral lifestyle interventions for obesity in community settings in persons with serious mental illness. She faced barriers getting her pilot work funded, including from grant reviewers who didn't believe that people with schizophrenia could overcome negative symptoms and to exercise and change their diet. I'm familiar with these barriers. I faced similar ones, facing grant reviewers who thought that people with serious mental illness couldn't quit smoking. But Gail persevered and led the first of its kind multi-site trial of a tailored behavioral weight loss intervention, the ACHIEVE trial. And this was published in the New England Journal of Medicine as a landmark trial that not only showed clinically significant weight loss, similar in magnitude to general population trials, but she had 95% patient follow-up. So she was really in the community doing work that patients believed in, such that they stayed in her trial. This trial was reported in the New York Times. I heard about it and looked into working with Gail after this. This paper received the International Society for Clinical Trials Trial of the Year Award, and it was incorporated into several international clinical guidelines, including by the World Health Organization. So Gail then broadened her focus to include other major cardiovascular risk factors like tobacco smoking, diabetes, high blood pressure, and high cholesterol. Many people have multiple risk factors, and she recognized this, and she asked me to join in her NHLBI-funded trial called the IDEAL trial that tested how well behavioral counseling and care coordination in community mental health programs could address all of these risk factors. And this study was the first to show improvement in risk factors with increased tobacco abstinence driving significant reduction in 10-year cardiovascular disease risk in those who received the behavioral counseling and care coordination. So this intervention is fantastic, and it will fit well into the growing numbers of programs that are integrating physical health care into mental health settings. So Gail and I, we met through the IDEAL study, but we then wrote and obtained NIMH funding for a trial of an intervention for smoking cessation that not only included people who are ready to try to quit smoking, but also some of the many people who are not ready to quit smoking right away, right when they enrolled. And this study it addressed weight as well. This trial was successful, and we've got more coming out on that. But basically, I'm honored to share this award with Gail. I look forward to our continued close collaboration and trying to get these interventions to develop better ones, but getting these interventions where they belong in the hands of patients and family members and clinicians. Take it away, Gail.
Thank you so much, Eden. That was really touching, and I'm very honored to share this award with you. Thanks everyone for being here, and to NAMI, and of course to the Peter Corbin Cohn Endowment. Now I'd like to talk about my close colleague and friend Eden. And let me say that we became friends through our work, not through residency training, not through anything like that, meeting at a conference. We really became close through our collaboration on this issue of physical health in persons living with mental illness. And really, Eden is an incredible trailblazer and role model. She is consistently really a star, and I think is probably the single most important person in the world who has influenced how we address smoking, tobacco smoking cessation in people living with mental illness. There's a lot more work to be done, but most of what we've been able to accomplish so far is really in large part because of her work. So let me tell you a little bit about Eden. She's the founder and current director for the Center of Addiction Medicine at Massachusetts General Hospital and the Cox Family Professor of Psychiatry in the field of addiction medicine at Harvard Medical School. She started out at the University of Virginia as an undergrad and then got her medical degree at the Medical University of South Carolina. She did an internship in pediatrics near me at Children's National Medical Center in DC, and then did her residency in psychiatry at Massachusetts Mental Health Center and at the Harvard Longwood Psychiatry Residency Program in Boston, where she was also honored as chief resident. She then conducted fellowships in molecular biology at McLean Hospital and at clinical research in the schizophrenia clinical research program at Mass General, and received a master's of public health in clinical effectiveness from the Harvard School of Public Health. So actually, Dr. Evans began her career as a more, traditional schizophrenia researcher, studying treatments to improve negative symptoms and cognitive function. But then her findings actually showed that nicotine helped improve some of the cognitive impairments. And when she was working with nicotine, she really started really seeing the toll of tobacco smoking on the overall health of her patients. And she started thinking about how to really study efficacy and tolerability of treatment for tobacco smoking cessation in people with serious mental illness. And she's in her own right, physiologic, behavioral, and functional MRI, researcher, and done a lot of work in cannabis and other substances, cognitive function and brain function. But really, for the past over decade, she's really been focused on smoking. And she has had a series of landmark studies that have progressively shown the importance of this issue and which treatments work. So for example, her studies on bupropion with or without nicotine replacement therapy, increasing smoking cessation rates, led to inclusion in the NIMH-sponsored PORT treatment guidelines for schizophrenia. And then, just as I was meeting her, her landmark maintenance treatment study was published in JAMA, showing that among people with serious mental illness who quit smoking with varenicline and group cognitive behavioral therapy, maintenance treatment with varenicline tripled the abstinence rates at 1 year. This was completely a vanguard study, because before then, people had really been thinking about smoking cessation in these shorter increments, get people to quit for several weeks or a couple of months. And her work really showed that, like many addictions or many chronic conditions, tobacco smoking cessation is really a chronic condition and can benefit from longer treatment. This work had direct policy implications because it led to incorporation of Medicaid insurance coverage for 1 year treatment with varenicline, first in her own state and then in multiple other states, which I think, there are not many of us clinician investigators that can actually say that our work has led to that. And then as a follow-up to that, she was a leader of the Eagles trial and senior author of the main report published in Lancet, that also was key in showing that people with mental illness do not have worse side effects from treatment with varenicline and other medications than people without. That was also key because that was an issue that many clinicians have been concerned about. And so essentially, she's really just advocated and has really changed the way that we think that people with mental health conditions who make up a majority of people that smoke should not be excluded from smoking cessation treatment studies or smoking cessation treatment. I will note that the Eagles trial was the largest smoking cessation trial ever conducted with over 4,000 people with psychiatric illness. And it was, again, landmark comparing all three first-line smoking cessation treatments. This trial, plus the combination of Dr. Evans' prior work, again, affected policy. It led to a removal of the regulatory black box warnings for varenicline and bupropion in the US and Europe, essentially removing a key barrier to effective smoking cessation treatment, and really opened the door for my work with her in really getting these practices out into the community in terms of how to really work with these medications and combine with counseling to have people stop smoking. I'm going to talk about one more soon to be landmark study that Dr. Evans has very recently completed, which was funded by PCORI, where she led a team that enrolled over 1,100 tobacco smokers with serious mental illness in Greater Boston, testing the effect of community health worker support and academic detailing on smoking cessation rates. Her media coverage has been very broad, not just the New York Times, but Oprah, Scientific American, Huffington Post, ABC World News, et cetera. It's very, very broad and wide. She is also a very productive investigator, well-funded from NIH, bringing in over $35 million in grants to Mass General over her work, and also having over 22 years of a continuous NIH funding, also funding from the Brain and Behavior Research Foundation. She's mentored over 35 junior investigators, many that have their own awards, and has authored over 150 publications. So Eden is a star. And I think more importantly than everything she's done, she's a wonderful person. She's creative, she's caring, she's exciting to be around. I love working with her. And I'm just so happy that we're sharing this award.
Yay. Well, what lovely conversation starters with your remarkable research and clinical histories. I'm going to invite people to submit questions in the Q&A. Make this as interesting as possible. I'll start with asking the two of you the same question. A family member recently asked me, I have a brother who has 50 pounds overweight, is inactive, and is a smoker. Where should we begin?
Should I, Eden, you want to
Gail,
start?
you want to take that? Let's start with Gail.
Okay, well, this is a really common issue where, people in the US often have multiple heart disease or cardiovascular risk factors, in particular with people living with a mental health condition. It's very, very common. Actually, probably more common than just having one. So I think that the way that I would suggest approaching this is, what does the person themselves want to do? What are their priorities? And so using a motivational interviewing approach to really understand their values, explore, provide guidance and information, and then, work with the individual to let them decide where to start first. I will say, and I'm sure Eden will agree, that, we know that tobacco smoking is, if you have to kind of address one risk, it's the one that if you address it and are able to quit, will most quickly reduce your risk for a cardiovascular event. However, we know that smoking cessation and all behavior change can be challenging. So I think, let's start with the person and what they'd like to address first.
Eden, I want to ask you a different question related to smoking cessation. What do you think about the idea of quitting multiple behaviors at once in order to improve the ultimate behavior, which would be smoking cessation? The associated behaviors, and whether that's drinking or coffee, how do you think about multiple addictions and attending to that?
So we've often not addressed multiple addictions at once for fear that, and made a hierarchy for fear that would reduce effectiveness of for any one, and that's actually shifted. So more and more people are asked to do to reduce or quit multiple substances at once if they're motivated to do that. We often ask people to reduce their coffee when they try to quit smoking, often because coffee triggers tobacco smoking. So to switch to decaf, or at least half decaf for some of the time, just and to work these changes into their life, so that it's doable.
Thank you, Gail. A question about activity, right? There's a literature on longevity and activity. What have you found in your research that helps promote people who live with mental health conditions to be active, physically active, exercise, walking, whatever it might be? What have you learned?
Right. So just to quickly summarize the literature, we know that increased activity at any weight or any age is related to decreased heart disease risk and mortality. So I think that's a really key point for everyone to know. So I think that what we've learned is that you do what you can and you try to be consistent, and that walking is great and is generally accessible to most people. So that the exercise, the physical activity does not have to be complicated. And there are lots of resources that I have, and also from the American Heart Association and the National Heart, Lung, and Blood Association, where it's, the programs are really focused on walking. And I think that that's a really good place to start. And that doing something, 30 minutes, 5 times a week is great. But if you can do 20 minutes, do that.
All movement is good, it sounds like.
All movement is good.
Eden, question for you. People say smoking helps manage their anxiety or their concentration. And I understand you think about it differently, that it may be a way to solve for their addiction. So I wanted to take that up. So people who feel that smoking is beneficial to them, what are your thoughts about that?
It's a totally natural way to feel, because when most people who are addicted to tobacco smoking smoke, they're in withdrawal. And so that cigarette makes them feel better. It totally makes sense, particularly say the first cigarette in the morning. The person's in withdrawal. That withdrawal anxiety is one of the key withdrawal symptoms, as well as sort of negative affect. And so their experience time and again, with cigarette after cigarette, is that they feel less anxiety when they have a cigarette. What they don't realize, and what they do realize after they quit, and the data are quite strong, is that once you quit smoking, your average level of anxiety goes down. So you reduce that source of anxiety, which is nicotine withdrawal. And a very nice paper, which was published in the British Medical Journal a few years back, summarizing multiple papers, really showed really convincingly that if you quit smoking within 6 months, your depressive symptoms go down, your anxiety goes down, and your perceived stress goes down a lot. The effect size was about that of an effective antidepressant medicine. So it totally understandable that people feel that it reduces their anxiety and they need it long term for anxiety.
Right. So, but it's a conceptual frame shift. They are right that they feel better when they smoke in the morning first thing, because they've been in withdrawal for 8 or 9 hours of sleep. But you're saying the meta point is much more complex than that.
Right. It's the withdrawal that's actually driving their discomfort and their anxiety, which will go away after they quit. And which is with the medicines that we use now, withdrawal, even with quitting, is really ameliorated. It's really better.
Gail, question I have for you. As you know, it's baseball season, it's playoff time, and I worry a lot about monitoring of major side effects, hemoglobin A1C, cholesterol, blood pressure, falling like a harmless pop fly, which lands between the internist, the psychiatrist. For a person who knows they're taking a second generation antipsychotic and wants to be mindful and drive the care, it probably doesn't matter who's following it, but what would be your ideal outcome of who follows it? And what should an individual be most mindful of in terms of the blood work that attends to the risk of second generation antipsychotic induced weight gain and diabetes?
Well, these are great questions. So I think that I don't think it matters who does the monitoring. I think that what we really like is that if there is more than one clinician providing care, so if there is a primary care physician or nurse practitioner, and there is a psychiatrist or psychiatric nurse practitioner, that there is some communication between those two people. Now, we often do not have financing and reimbursement mechanisms to support that. We do sometimes, and in some cases, and that's some of the work that I have done that I'm interested in continuing to work on. But I think the key is that there's some communication between the two. So the psychiatrist might draw the blood work for cholesterol, but then he or she may speak with the internist about actually treating. And there can be some role overlaps, right? Depending if someone's in a rural setting and doesn't have a psychiatrist, or if the psychiatrist is playing that role of, they're starting blood pressure medication or whatever. I think that in terms of what the individual with mental health condition would want to do, or with their social supports or family members, is really know what monitoring they should be having, as you alluded to. So knowing that they want their blood sugar checked, their hemoglobin A1C, their cholesterol levels, and their blood pressure and their weight, and that serving, if the coordination between the two clinicians is not already in place, serving as a self-advocate or having a family member serve as an advocate for that coordination. So reminding the clinician, hey, would you mind reaching out to my psychiatrist? I see my A1C is up, or to the psychiatrist, hi, just want to check to make sure. This is my internist. Could you speak with him or her, et cetera? So trying to serve the link. In a perfect system, we wouldn't need that as much, but the systems aren't perfect right now.
The NAMI program, Hearts and Minds, includes, we've revamped that program, which, we jump-started a long time ago. We've just re-released it. And that has all the information for individuals, what should be monitored. It is very local on who might do the monitoring, but I encourage you to check that out on our website. We got some substantial support from several of our sponsors, because there is no quality of life without quantity of life. Eden, you're going to like this question. What can I do to support research?
Well, you can volunteer for research.
A person in the audience asked.
Yes, support people participating in research is probably the biggest thing.
So how might I do that?
Well, there are ways to locally in university, there will be a research program who's generally speaking about the studies that they're doing online. I don't know if NAMI points people to research in
clinicaltrials.gov is kind of our go-to, because that is at least, all IRBs, and, they've done some of the heavy lifting.
Yeah, and if people have means, we're always looking to support junior faculty to learn to be the next generation of researchers.
Thank you. Gail, question about COVID, the pandemic, and people's mental and medical well-being. What have you seen? What can we do about it?
Well, that's a whole nother session probably, but yeah, so we know that COVID has affected probably almost everyone's mental well-being. So both people that, had a prior mental health condition and those that are kind of developing them over COVID. So, and then similarly, medical conditions that are not COVID related, both in those with and without a mental health condition, may not have been able until recently to get the attention that they need because of resources and hospitals and other healthcare systems that have been really tailored more towards COVID or transportation, other issues about, getting regular preventive care or even some surgeries performed. So there's been a lot of stress on our medical system and really on the whole country. So I think that in terms of things, are opening up somewhat, or depending on where you are in the country. I think that really looking at your supports, working with your family, working in your community, communicating with your healthcare providers that you have, trying to maintain those relationships, even if they're hybrid or phone, and just, I don't want to say doing the best you can, but I think we're all doing the best you can right now. I think, NAMI has great resources. And I think that, healthcare providers are stressed themselves, but I think are, very willing to help.
Thank you, Gail. Eden, a question for you about disparities. Of course, the population of people with mental health conditions is already a disparity, and you've done a lot of good work to make sure they're included in research studies. What about other disparities? Social determinants of health, racial, ethnic, gender disparities. What do you notice in smoking cessation as you think about those demographic groups?
Well, we don't know very much about the social determinants of health within people with serious mental illness. We know that in the general population, these disparities are enormous. They may swamp even some of these cardiovascular risk factors that Gail and I have worked on for our careers. They may be as big as, obesity or lack of exercise and that sort of thing. We're really struggling to define them. And I think what we know now is they are large. What we've done in looking within our samples, we are not finding essentially additional disparities over and above having serious mental illness. And it may be that that's such a big risk factor that adding others on top don't have an additional effect. But we've only looked in our right now samples of say 1,100 people, which in the scheme of things are small, and with a 2-year follow-up, which in the scheme of things isn't long enough. But it's a great question, and again, we've scratched the surface in terms of say self-reported race and ethnicity. We haven't looked into language disparities, et cetera. We've only scratched the surface in our work and others.
Great. Gail, community health workers, the peer movement in cardiovascular prevention. So I'm just going to give you a statement and let you riff off of that. Where's awesome. It going? Go ahead.
That's awesome. We were actually just talking about this in a team meeting today. And so I actually think that, so community health workers have gotten, a lot of traction in recent years in kind of the overall population settings, particularly urban areas and areas with, and some racial disparities. I think that peers can really be the next quote generation of community health workers. I think that we, both Eden and I have done work with peers, and we'd like to do much more work with peers. I think they are, I don't want to say a completely untapped resource because people are using them, but I think we need more research into what are some of the best ways for enabling, training, even paying, certifying peers to do this kind of really important work. I think the work that Eden and I are promoting is really, some of it is kind of task shifting, particularly maybe in the space about weight and diabetes and that mental health, the mental health workforce is stressed, there's turnover, it's COVID. And so if we can work with peers, I think that, that is a great resource to really do this and move this work forward.
Thank you.
I'm going to jump in there.
Same question.
I'm going to jump in.
Same question. Okay, yeah.
Yeah, so we're finding that community health workers have an enormous impact on smoking cessation, and they really, the CHWs that we employed and tested in our large PCORI trial really had an open-ended mandate. Like the old-fashioned, go out there, make a relationship with folks, try to get them into their doctor, try to get them interested in smoking cessation if they aren't already, and if they are, try to help them through the practical barriers. But they had seemed to have had a much bigger effect than that, or a very large effect, and it's essentially was building a relationship, which building trust and essentially building community by bringing people into group programs, et cetera. And I think that's why they may work, as Gail said, in urban settings where some of the sort of community connectedness has been is less cohesive than we'd like, put it that way. So I think that it's a low tech, high touch, which isn't so in vogue with all the apps and all out there, but it seemed to have a large effect, and it may be that it's untapped really, or undertapped in this country. We know in many other countries, community health workers are quite cost effective, but they've been understudied really in serious mental illness, and I'm really optimistic that we're going to find that they can really boost people's self-care and sense of well-being as well.
Thank you, Eden. Yeah, thank you both. Gail, where's the research going? Where does it need to go?
So thanks for that question. So I still think we need to test different evidence-based interventions, evidence-based practices for the range of cardiovascular risk factors and even other physical health issues, for example, cancer. However, I think where the field really needs to go right now is more towards implementation science, which is what Eden and I have done some work in and are really looking to the future, because we have enough evidence-based practices for cardiovascular risk reduction, including smoking cessation, but they need to be put into practice. As I mentioned before, the mental health workforce is stressed. The community public mental health workforce particular with COVID. We need to we need to understand how these practices can be really translated into community settings so that, quote, real world clinicians and other kinds of providers, whether it's community health workers or peers, can deliver them in a way that works within their workflow, where the training isn't too onerous, and where they'll be able to be baked into the practices, the settings, and sustained. So that's a whole line of research that really needs to happen, and soon, I think, for us to really be able to make change in physical health.
I totally want to echo that. We need to figure out how to implement what treatments we do have, sort of identify and overcome the structural and other barriers that are very real for people living with serious mental illness to get just evidence-based medical care.
Eden, I'm going to stay with the smoking question, which has come up more than once in the Q&A. How do other forms of nicotine, other than smoking, affect cardiovascular risk factors? So this is everything from chewing to, you pick vaping if you want to take that on, the other elements of nicotine delivery.
Right. So chewing is in a class by itself because of all the cancer risks. But there are lots of clean forms of nicotine, like nicotine patches, nicotine gum, nicotine lozenges, which in the scheme of things don't raise cardiovascular risk much. They increase your heart rate a little bit, but compared to smoking, there's just no comparison. My dad was a 3-pack-a-day smoker. He's been on the nicotine gum since about the year 2000. So he's still on it, doesn't want to stop it. And sort of the risk benefits really is a no-brainer, if you will. Quitting smoking, as Gail showed in I think the IDEAL trial, I get your acronyms mixed up there, Gail, but I think showed that she was able to reduce the 10-year cardiovascular risk really the mover on that was tobacco smoking. And we've thought for years that some people may need long-term either nicotine replacement or a nicotinic agonist, because nicotine does improve some cognitive functions in people with serious mental illness. So the cardiovascular risk is low compared to smoking.
Follow-up question from a person asking about her son with bipolar disorder. And the question of self-medication for things like smoking, that the interpretation is, illicit drugs are being used, to deal with some of the smoking related consequences of trying to quit. The different version of self-medication. I just wanted to ask you a little bit about how you think about self-medication.
In terms of, I'm not sure I followed the question in terms of smoking is self-medication or?
Yes, well, I'm going to let you
smoking?
take it wherever you'd like to go.
Okay.
Right, you're an international expert on addiction and mental health. And so self-medication is the topic generated by this question.
Sure. So I, on the one hand, I like to think of medications as something that help you over the long term. And a lot of, drug use is not in that category. It helps you in the short term. So, alcohol may make you feel better from depression or anxiety for a very short time, but long term, it's really bad for those problems. So, nicotine may help in the short term for stress relief or anxiety reduction. And so switching on to an agonist treatment, a treatment that acts like nicotine in the brain and the body, can reduce the harm of smoking. But still get the drug related self-medication. And if you needed to vape, that's vaping has its own harms, but they pale in comparison to tobacco smoking. So it certainly is a reduced harm product. And so that's really what we're about, right? Giving people options to improve their lives, to be more comfortable, to be more the people they want to be. And so there are lots of options to help people to minimize harm. And I guess talk with your doctor about what you're trying to medicate and see if you can't get a better medication for the things that are bothering you.
Got it. Gail, last question for you before we do the virtual award presentation. What would you like to know about Gail, or what do you enjoy about Gail that has nothing to do with her world renowned research? Like, what would you two do for fun?
You mean Eden?
Hang out for a day. Eden, what would you ask Gail? What would you do with Gail if you had an afternoon and you couldn't talk about research?
Oh, I know. Well, I know what we do.
I'm asking Eden that question.
Oh,
but I'm
okay.
coming to you, Gail. I'm going to give you a minute to think about it.
Okay.
Just going to the personal friendship.
Okay.
Oh, I think any number of things. I think we're going out on the water together, so on a nice sunny day, or cooking something good to eat, and talking about the kids and just enjoying each other's company. It almost doesn't matter. If we got time to spend together, we'd have a good time.
Pals together. Gail, last question. Same question about hanging with Eden for an afternoon. If you're not allowed to talk about this work that you do.
Hanging with Eden brings things to a whole other level for me. Pre-COVID, we were together in New York for, I think, what was a conference, which we did attend the conference, but then we saw a Broadway show, and then went to a very nice dinner that I actually was not even allowed to tell my husband what that credit card bill was. And apparently it's a place that Eden had, been at least once before. So with Eden, I, enjoy the finer things, but also, the simpler things like, just taking walks and being outside.
All right. The regular good stuff. All right. Well, it's been a great Q&A. I'm really sorry this wasn't in person. Having two such remarkable standout researchers devoted to a core issue that matters to people at NAMI would have been so much fun. And at least I think we spared the audience the pain of PowerPoint for one time, and to get to know you just a little bit. And I'm going to follow up with you, Gail, on that credit card bill, just so you know. So now I'm just going to tell you a little bit about the Scientific Research Award. The Scientific Research Award has been given from the National Alliance on Mental Illness since 2003. So we're coming up on 20 years of America's all-star researchers. And we have covered the waterfront of great ideas, great researchers, and great thinking. And I want to take a minute to talk about George and Uta Cohn, who underwrite this entire award series with an endowment. And their devotion to what is called the Peter Corbin Cohn Endowment. It was established in 2013 in loving memory of their son, Peter, who slowly progressed his illness and morphed from depression with psychotic features to more paranoia. Through this endowment, the Cohns hope to expand the role of the family to develop adequate approaches and better understanding to research. The endowment provides researchers with more opportunities to improve the lives of people who live with mental illness and their families. I want to say the Cohns are family friends of NAMI, and we greatly appreciate them. Would this be in person, we would have them give remarks. So, Gail, I just want to say I am honored to present the NAMI 2021 Scientific Research Award for your fantastic research in cardiovascular prevention. And wait, it's not all virtual.
Can I hold? Okay, thank you. I didn't know I had this. Thank you very much.
There we go. All right. We're going to do your remarks and accepted speech in a moment. Eden Evans, I met you a long time ago. You were a young, brilliant researcher, and it's my great honor as NAMI's Chief Medical Officer to acknowledge your really remarkable work on smoking cessation for people with serious mental illness with the 2021 NAMI Scientific Research Award. Gail, you want to give remarks about accepting your award? Eden,
Yes.
I think yours is coming. Hold on. I'll get my best people on that. Gail, so now you've won the award. All right. You can relax for a minute.
Yeah.
Just take it in.
Okay.
What do you have to say about winning this award? What does it mean to you? What does your work mean to you?
Thank you so much. So I'm really, really honored to receive this award. I mean, I think neither Eden or oh, there it is. There's her award.
There we go.
Yay.
There we go. The UPS guy isn't always on time, but we love him anyway. We thank him every single time. Yay. All right, quick round of applause. All right. So Gail, all right, so let's go back to you and talk a little bit about your
I'm
award.
really, I mean, it's weird over Zoom, but I am very emotional. I am very, very honored to win this award. I don't do this work for awards. And in fact, one might argue my career kind of went kind of maybe against the grain of a traditional internal medicine researcher who, I didn't start on something that I could do a quick cohort study or join a larger study and have 200 papers in 5 years and get all these early awards. In fact, I mean, my awards are very, very, very few. And so I think even more honored because of that, and really because NAMI just embodies everything that I believe in and that I have worked for and that I will continue to work for. So I'm extremely appreciative to NAMI and the Peter Corbin Cohn Endowment. I wanted to thank everyone for being here during this time of what I would call extreme Zoom fatigue. It's so difficult to have these, quote, social events over Zoom, and I really appreciate it. And I know that Eden and I both intend to be there in person next year. Hopefully that will all be great. I wanted to thank the organizations and people who have funded my work, NIMH and NHLBI, the Brain and Behavior Research Foundation, formerly NARSED, and really the individuals at those organizations who have really believed in me and given me guidance through applications and revisions and support and provided me with a network of researchers and colleagues and really have encouraged me. I want to thank my mentors and colleagues at Johns Hopkins and elsewhere. I'm extremely fortunate to have learned from them and worked with them over the years. They have provided me guidance and really I wouldn't be able to do this without them. I wanted to thank the multidisciplinary team of staff and faculty, many of whom I've been working with for over 15 years, who were not necessarily engaged in this kind of work before I encouraged them all to come together. They really conduct the highest quality research, the most creative research, and have really, with respect for the communities that we serve and work with, and I learn from them every day. I want to thank the community programs, all the stakeholders, and especially the study participants, which I have almost 1,000 now, maybe more over the year of participants, not programs, over the years that have really opened their doors and allowed me to work with them. I do want to thank my family, who have stuck by me and encouraged me and allowed me, facilitated me being able to do this work in a dual career family. And I want to just also say to those of you in the audience who may be funders or potential funders, I do understand that, basic science brain discovery is critically important to psychiatric and mental health research. But I think also, I think Eden and my work hopefully show that this area of, services work and addressing medical comorbidities and implementation science is really important to so that we can help people get the tools soon to really achieve health equity for persons that are living with mental illness. We need to devote resources to this so we can know how to best implement what we know works. And so even a small amount is good for that. And I really think more work is needed in this area. I look forward to doing that work. Thank you so much.
Thank you, Gail. Congratulations. Fantastic. Our first internist of all time winning the award. Yay. I should mention that not only did Gail do an Ask the Expert on cardiovascular prevention, when I asked her to do one on the vaccines back in January, when there was a lot of controversy, she brought a team of people together and just made it happen. So you're definitely part of the NAMI family, Gail. And once you're part of the family, look out. Eden, a time for remarks or speech as you prefer.
So I just want to thank you, Ken, great mentor over the years. And thank you, Dan, for leading NAMI. And thank the Cones for supporting research in general, as well as this award. To me, the NAMI award is different from other awards. It's more meaningful because NAMI represents people living with serious mental illness and their families. And what's more, the fact that NAMI is honoring the work that Gail and I do means they think it's important, right? So that's the most important thing. So focusing research to me in areas that are important to the people living with serious mental illness and their families is critically important. And it gives us the validation and the energy to keep at it. To keep making progress. Our work literally seeks to empower people to minimize their health risks, to improve survival, both in their life expectancy and the quality of those years. I started this work as a fellow when in 1 week, when I was working in the clozapine clinic, a 40-year-old man in my clinic, young man, I would say now, who smoked 3 packs a day, died from sudden cardiac death in his bed. And then 2 days later in the same clozapine clinic, a 44-year-old man came in wheeling supplemental oxygen tank that he needed for severe emphysema, right? I was busy studying the glutamate hypothesis for negative symptoms and cognitive dysfunction and schizophrenia. But those people impacted at such a young age by smoking-related suffering and death, that's what sort of turned my career. Right now with their Hearts and Minds initiative and with this research award this year to our research to reduce suffering and death from heart disease, NAMI has really planted a flag, emphasizing the importance of addressing cardiovascular health and reducing this disparity in cardiovascular mortality that's sort of shocking, except that it isn't. It's been accepted. So I don't know, Gail, I take this award as encouragement to work to improve the delivery methods for these treatments that we've proven work, and reduce barriers to the existing first line smoking cessation treatments, et cetera, and to work to develop even more effective ones. And I'll just thank a few people, mentors for many, many years, Don Goff and Maurizio Fava here at MGH, Ivan Montoya and others at NIDA for funding this work and caring about this work for 22 years. Penny Moore and others at Picori for funding us to go into community-based work. Thank my kids, Eloise and Henry, for putting up with a working mom, and to my fantastic team at the Center for Addiction Medicine. Just couldn't be better colleagues, collaborators, students, and it takes a village for sure. So thanks very much to all of you.
Well, we're really glad you both are part of our village and the extended NAMI family. Dan?
Thank you, Ken. And as I go on to read and share with you some closing comments, I just want to think about some words that came to mind as I was listening to the questions and answers, as well as your acknowledgments for the awards. First of all, thank you. And second, it just made me think about a few descriptive words: energy, passion, focus, tenacity, great attention to detail, and peer support. What I heard you guys talk about amongst each other talks about peer support and the critical importance of relationships and peers speaking with each other. And I will just close by saying in these comments, caring more than people expect. Because research can be lonely, research can be long hours, and research can be testing before you get to the conclusion. And that is caring more than people expect. So just on behalf of us, I want to thank you. And now I'll go into the formal comments if you all are okay with that. On behalf of our board, staff, and entire community, congratulations, Gail and Eaton. From all of us here at NAMI, we are proud to add your names to the eminent list of our former award recipients, many of whom are with us this afternoon. We look forward to learning more about your work as you continue to make a difference in the world of research. As you know, NAMI's role in research is one of the essential pillars of our mission. We are constantly seeking ways to address the growing concerns of those struggling with mental health. Your research helps us move forward and provide support for the millions of people with mental health conditions and their families. We appreciate having so many of you join us today for this event. Research can truly alter the course of people's lives for the better. We are committed to continuing to support and advocate for more mental health research, and we hope this work will inspire the future. Research makes a difference. Remember, no matter how you are affected by mental illness, you're not alone. I'd like to pause to thank a special thank you to the Howard University Jazz Ensemble for providing today's musical interlude. Howard University, you know. To our sponsors and supporters, we send you our deepest thanks and appreciation. Together, we have the power, opportunity, and responsibility to elevate the conversation around mental health so that people can get the care they need and deserve. Let's really hope that next year finds us celebrating our 2022 honorees in person. And we hope to see you then. To everyone, thank you and congratulations very much, Eden and Gail. We appreciate you. All the best.
Thank you so much. Thanks, everyone.